Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Yemi Famuyiwa, fertility specialist. Today's Kevin MD article is Infertility Public Health, the WHO's, the World Health Organization's new global guideline. Yemi, Happy New Year, and welcome back to the show.
Thank you. Thank you for having me. Happy New Year.
All right, what's your latest article about?
So it's really impressive that infertility, as I've been talking for a long time, we all know that they recently assessed it as 1 in 6. But I think the WHO, they took this one step further by making it, this is their first ever where they created a white paper about it. They made standard recommendations for it, and they want to elevate it to a global stage. But what this document did was they say that fertility treatment should be available worldwide, right? And they make recommendations, some specific recommendations, but they also took into account that not every place has the right resources.
Mm-hmm.
So they're taking it down to what can we do even in a low resource setting? Let's create some standard guidelines that can be used in these settings in a systematic fashion that may help. And if resources are available, like in a high technology place like the US or the UK, then what other guidelines will there be? They also acknowledge that some of the guidelines, they try to use what is called the best available science. We all know the best available science may not be available to everybody. So they said, well, in that case, can we extrapolate to a low resource setting so we can still get care for people who need it? And they came up with 40 guidelines and speak 6 specific best practices guideline, out of which they base it on the strength of the evidence available. And out of all of those, there's only really one that they make like a really strong recommendation about. And then the other ones are sort of low-hanging fruit where they say, well, if you can do these other ones.
So just for some context
Yeah.
around the paper, what led the WHO to write this paper? And is this the first time that they've addressed infertility in this fashion?
This is absolutely the very first time. We all know fertility is declining worldwide. So what they did was they came up with a multidisciplinary team to acknowledge this as a health issue. Now, the thing with infertility is when you hear the WHO saying this is a problem and we're going to try and give you guidelines, in some countries, that may be extrapolated to the government now saying, well, maybe we can allocate some resources and try to address this. And they don't really, the WHO doesn't jump right into high tech. They try to say, well, you can even see it as a public health issue, right? So where people encounter their initial care, their primary care doctors can start talking to them about it. We can promote health education that can be, low cost, taught in maybe schools, because a lot of people have no idea that some of the things that they are doing with their bodies have an impact on fertility. So they're saying, well, if we can disseminate this information all the way down to the primary care level, to the, make it almost like a PSA statement, and then make it gradual so that there can be a progressive workup. I think the reason they wrote it is because it's so prevalent, and they're saying, you know what, if we can even start talking about it so early enough, we can avoid some of the more complicated issues down the road, and that may actually translate into cost savings down the road. You get things before they get worse.
Now, in low resource countries,
Yes.
just give us a picture. What is infertility treatment or options like in low resource
Yeah.
countries?
So what they did was, again, they helped to say, okay, how can we first diagnose it? All right, let's make sure that ovulation, let's agree on what to call ovulation, right? So in the low resource setting, instead of going straight to an ultrasound, let's do a mid-luteal phase progesterone level. And if it's abnormal, repeat it with the next level, right? So in a low recess setting, let's do a semen analysis. And if the semen analysis is normal, then you're good. But if one semen analysis, one parameter out of the semen analysis is abnormal, then repeat it in 11 weeks.
Mm-hmm.
Right? So the sperm, you get new sperm regenerate every 72 days or so. So they say, well, count 11 weeks, repeat it. And if it's still abnormal, then it's a big issue. Then you can look at, does a person have a varicocele that needs surgery? For the women, do they have a hydrosalpinx that needs to be removed? And then can you diagnose either unexplained infertility and PCO, which is very prevalent? And if you do, here's a systematic approach for unexplained infertility. Go through this low resource algorithm first, right? Let's see if letrozole will do the trick. And that's the treatment of choice. I know a lot of people think that Clomid is, but I think the literature has settled that equation out. Letrozole is the treatment of choice to begin with. And if it doesn't work, go systematic. Use gonadotropins with IUI. And if that doesn't work, then go to IVF, right? So it doesn't abolish IVF, but it says, let's be systematic about it. And then for PCO, the same thing. Let's cut out a systematic manner. Another low resource setting, you can, if you're really good at it, if you've been doing it a long time, use an ultrasound to evaluate if the tube is open, if the cavity is okay. Yes, you're going to have false negatives. Yes, it's not as good as having an HSG or being able to do the high-tech stuff. But if you're good at it, if you've been doing it a long time, you can do a hysterosonogram and see if there's a polyp. And if you're really good at it, you can actually even see fluid tracking out the tube or air bubbles going out the tube. Now, you have to be comfortable and good at it. So that's a low resource setting that you can use. Yeah, a 3D ultrasound would be wonderful, but you may not have that available, right? So we can in other words, you use what you have and see if we can get the biggest bang for your buck with what you have. And if a patient needs IVF, then they need to be guided towards that without wasting additional time.
So it sounds like these new WHO guidelines or in a paper, it gives a more systematic, algorithmic
That,
approach to people in low
yes,
resource settings to best utilize what's around them.
yes. And the way I read this document, it's meant to be a living document. So they realize that there are gaps in the literature. They realize we don't have as much scientific data for some countries all over the world like we may have in, say, the Scandinavian or in the US. So they comment that, yes, we know that there are gaps, and this is only a beginning. And it's so interesting that these are all the things that I try to do and I talk about, especially in my upcoming book, where in my book I extrapolated, and I think I'm not sure how often they're going to renew this document, but the next step they talk about is, let's look at exposure, let's look at lifestyle, let's look at toxins. And I already do that in my book that's coming out. So hopefully those will be addressed in the upcoming guidelines that are coming forth.
So without these guidelines, I think I read in your article, in low resource countries, people resort to unsafe treatments,
Exactly.
things that may not be
Yes,
medically legitimate and actually put
exactly.
women at harm.
Yes, absolutely. I'll give you an example. I had a patient who had fibroids who came to see me. I won't mention from one country. And she said she went to a herbalist to get this treated because maybe she didn't have access to the clinic or didn't trust the clinic. I have no idea why. But she had something inserted in her vaginal cavity. And she stated that it burnt at the time, but she was told to lie down and bear the pain. And it would dissolve her fibroid. So she did, in excruciating agony. Well, when I examined her, it was like somebody had literally melted her vaginal cavity, was all scarred up. And there
Wow.
was a very tiny, tiny, tiny passage, maybe where she got menstrual effluent. And beyond the scarred vaginal area that was all sealed off was still the fibroid uterus that's still there. And I showed her on the ultrasound, like, I don't know what they did, but it's still there. But I tell you what, now you have severe scarring, and she's going to need like plastic surgery to undo that. And additionally, will need surgery on the fibroid that was never taken care of, right? So if there are guidelines, women won't resort to some of this, I call it desperation medicine, but they don't know better, right? And there are no resources. Yeah. And it's a mental agony for these women.
So we've talked about how that paper addressed infertility in low resource settings. Tell
Yes.
us some other takeaways that you got from the paper.
I think what the biggest takeaway is, number one, they do come down and really very hard and say tobacco use is bad. That one's unequivalent. They give the 5 A's of how to approach it. Ask at the time wherever you encounter the person, do they smoke? And then you want to find out if they need access, if they need help getting over it. Are they ready for it? Are they mentally ready to go to change? And also assist them with coming up with a plan, and then also advocate for follow-up. So that's the only thing that they come about. But I think in essence, what it does is it gives women who are struggling in some of these countries words for what they're going through. Give, oh yeah, this applies to me. It gives language to care providers that they can use to connect to patients, and also may spur government initiatives.
Hmm.
Now if it's the World Health Organization talking about it, governments may move because they make policy that affect the health ministries, right? So that may help, initiate government support that may help this women down the road.
Are there any areas in this document that fell short or something that you would like to see more of addressed?
I think that they did talk about it, which they didn't really address it. The gaps will be in the next step, right? The exposures, how low hanging fruits, how those can affect you. What can you do with your lifestyle, your weight management, not just tobacco use again, but alcohol? What are the other things that people can do that's low hanging? But I think more importantly, one of the things that I felt excited was because this document says that IVF is an important part of fertility. It's not the initial go-to part of fertility, but it's crucial
Mhm.
because there's been some in the general, you hear on social media where some people are saying, well, I forgot regenerative medical care, I guess they're calling it, can replace IVF. They're saying you can do all the preventative stuff, you can do all the initial workup, but IVF is still a crucial part of your armamentarium to treat fertility.
How about here in the United States? How does this document affect what you do as a fertility specialist and the patients that you see here in the United States?
It doesn't affect what I do because I already do all these things, right? But I think it helps because I'm trying to encourage my colleagues in the primary care field, in the family medicine field, in the OBGYN field to help with the initial workup. Like, I don't know if I explained to you, I recently signed a contract with Kaiser to be seeing their patients, and I'm so excited about that. And one of the things I do is go to my Kaiser colleagues and say, hey guys, you can really help me out. Before you send me this patient, you can do da 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 da. And I give them, this is the initial workup so that when they come to see me and they have all these done, I can speed up
Hmm.
my treatment plan because all that initial stuff has been done.
So, as you know, I'm a primary care doctor. Tell us about some of the
Yay!
workup that we can do before
Right.
sending patients to you.
Yay! Okay, so like assessing their day 3 hormones, for instance, checking their blood work on the second or third day of their period for FSH, LH, estradiol, progesterone, checking their anti-Mullerian hormone is just a blood work, having them get an HSG or something similar to see if their tubes are open, the cavity is normal, have their partners get a semen analysis if they have a male partner. If you would have done that, just that alone, you have done 90 or 95% of the workup. And when they come to see me, it just access to treatment just expedite just with that basic one alone.
So, what about next steps? What do you see from a policy standpoint as it relates to infertility in the coming year or so?
Well, the next steps will be for some governments in this low resource setting to step in and start allocating funds to it. Next steps in the US is going to be a tough one because medication is so expensive. I'm begging Mark Cuban with Cost Plus, please, please, please invest in fertility medications. It's just killing everybody. If you can get to a point where medication is more affordable, a lot of this drama will be removed.
We're talking to Yemi Famuyiwa, fertility specialist. Today's Kevin MD article is Infertility Public Health, the World Health Organization's new global guideline. Yemi, as always, let's end with take-home messages that you want to leave with the Kevin MD audience.
Take-home message: infertility is a real struggle, and there is help out there, and there's systematic help, and there are things you can do to even prevent some, not all, some of the causes of fertility. Stay tuned, follow, and read more.
Yemi, as always, thank you so much for sharing your
Yeah.
perspective and insight, and thanks again for coming back on the show.
Thank you so much for having me.